Hello and welcome back. We are going to talk about fluids and pH in this lecture. So let's get right into it. There are 4 different factors that are regulating fluid levels. The first is the renin-angiotensin system. So this is involving the juxtaglomerular cells, angiotensinogen, angiotensin 1, angiotensin converting enzyme, that's what ACE stands for, and angiotensin 2. More about this in a second. There's aldosterone. This is secreted by our adrenal glands. This is responsible for the reabsorption of sodium, and wherever salt goes, water follows. There's antidiuretic hormone, also known as vasopressin. This will insert water channels, also known as aquaporin 2 channels, into the distal convoluted tubule, as well as collecting ducts. So again, as aldosterone functions, reabsorbing sodium, these aquaporin channels will allow water to be reabsorbed as well. So again, all of these are going to increase the reabsorption of water. All of these are going to or cause vasoconstriction. So all of these 3 are going to cause an increase in our blood pressure. The only one that is doing the opposite, or lowering blood pressure, is atrial natriuretic peptide. And as a reminder, we saw this in an earlier lecture. It's the stretch of the atria of the heart that causes the release of atrial natriuretic peptide. It slows the release of renin, which is involved in this system, and the formation of angiotensin 2, again right back here. It also promotes natriuresis, or sodium in the urine, and when more salt is being released into urine, water is not being reabsorbed, so you're also flushing out water, and therefore you're decreasing your blood volume. Now I have this handy dandy diagram. Unfortunately, this is not in your PowerPoint slides. However, it is here. I'll put it up as an image separately. It's a nice summary slide of renin, angiotensin, and even aldosterone. So again, let's take a quick look at this. We'll go by the numbers. There's a decrease in either blood volume or blood pressure. So that's either due to dehydration, sodium deficiency, or hemorrhage. That results in a decrease in blood volume. That results in a decrease in blood pressure. The juxtaglomerular cells of the kidneys are going to pick up on this. They will increase the secretion of renin. The renin is going to convert angiotensinogen into angiotensin 1. Now, angiotensinogen is the inactive form. It is constantly being produced by the liver and circulating in our bloodstream. So it will stay inactive unless it comes into contact with renin. Right? So basically, the kidneys, by modulating how much renin is being secreted, will modulate how much this angiotensin 2 ultimately gets formed. Okay? But again, just real fast, kidneys producing renin, liver produces angiotensinogen in active form. So anyway, renin converts angiotensinogen into angiotensin 1. This is not a very highly active form of angiotensin. There is something called angiotensin converting enzyme that's located in the lungs. So as angiotensin 1 is circulating in the bloodstream, all the blood eventually goes to the lungs, and it is there converted into angiotensin 2. Again, we'll just follow the numbers for right now. Angiotensin 2 will impact the adrenal cortex by causing it to release aldosterone. And then aldosterone, as we mentioned just a moment ago, causes a reabsorption of sodium. And wherever salt goes, water follows. As you're reabsorbing more and more water, you're increasing your blood volume and thereby increasing your blood pressure. The other thing that angiotensin 2 does is the vasoconstriction of arterioles. So again, as we vasoconstrict our arterioles, we're going to increase our blood resistance, which will also increase our blood pressure. So this is a nice summary slide of the whole renin-angiotensin 1, angiotensin 2 system, as well as aldosterone. So what about alcohol? You may have heard of people breaking the seal if they've been drinking a lot. Basically, alcohol is going to inhibit the release of antidiuretic hormone. So again, antidiuretic hormone means reabsorption of water. So if we're inhibiting something that causes us to retain water, we're naturally going to lose it in our urine. Caffeine, often caffeine has a diuretic effect too. It's a different mechanism. It's inhibiting the reabsorption of salt. Again, Wherever salt goes, water follows. So if you cannot reabsorb as much salt, guess what? You're going to lose it in your urine, and again, that you will therefore retain more water in the urine as well. Okay, so that was the main factors that are influencing our fluid levels and our blood pressure. What about ion regulation? So a few things to know here. Sodium is the most abundant extracellular ion, right? And this should not come as a surprise. We know our sodium-potassium pump. It pumps 3 sodium out for every 2 potassium that is pumped into the cell, so it's no surprise. There's a large concentration of sodium outside the cell. That's what extracellular means. Now, in our American diets, we tend to eat more salt, frankly, than we need, especially if you're eating like processed foods, but our average daily intake exceeds our normal requirements, so it's not like you need to take salt pills. Again, aldosterone will cause the reabsorption of sodium. Antidiuretic hormone release will cease if sodium levels are too low. So you actually will produce dilute urine until sodium levels are on the rise. It is really, 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 did I say really important to have proper sodium levels. If you do not, if your body becomes isotonic because you don't have enough salt, it can cause neurological problems, including like seizures and death. So it's really important to maintain the right sodium levels. Atrial natriuretic peptide increases sodium water excretion if sodium levels are too high, right? So it's going to be operating, again, to get rid of any excess salt. If you have too much sodium, it's called hypernatremia. Excuse me. And you don't have to worry about this number or anything like that. It's just there for your information. One of the big issues is as you're retaining salt, if you have too much salt, you will also retain a lot of water, and this can cause edema or swelling. Sometimes the causes of sodium retention are renal failure, your kidneys are not flushing it out like they should, or too much secretion of aldosterone. Again, aldosterone will cause a retention of salt. So if you're producing way too much aldosterone, you're going to retain more salt than is necessary. The opposite of hypernatremia is hyponatremia. So this is when there's too little salt. And there's different reasons why this may occur. So again, it can be, I should say, a life-threatening situation. So it can occur due to euvolemic hyponatremia. So basically what's happening here is that the total body water is going to increase, but the body's sodium content stays the same. So this would be a situation where maybe you're outside, you're sweating, so you're losing salt, and you're only replenishing it with water. So again, your total body water is increasing, but your sodium concentration stays the same, or I should say your sodium content stays the same, so it becomes less concentrated. Hypervolemic hyponatremia, both sodium and water are increasing, but the water gain is greater. So again, you're just not absorbing or you're not ingesting enough salt. And then hypovolemic hyponatremia, water and salt are being lost, but the sodium loss is greater. So this sometimes may happen via, again, either kidney dysfunction or I don't know if it really happens with sweating. Usually you're losing as much water as you are salt, but anyway, these are the 3 different ways primarily that you can have hyponatremia. And if you want to learn a little bit more about it, I've provided a link for you. So as far as extracellular ions go, chloride is the major extracellular anion, so negatively charged ion. And basically it's there to help balance other anions. It moves pretty easily between cells and between areas because there's lots of chloride leakage channels. So it's really there to maintain a balanced charge. Now, that we don't really talk too much about it. You go into more cell physiology things and you'll learn a lot more about chloride ions. The big thing, though, is that chloride ions are incredibly important, and if you have dysregulation in chloride ions, what can happen is a buildup of mucus in ductworks, air passageways, and this is what's known as cystic fibrosis. So you can see here it's a condition where the membranes of cells that produce mucus, sweat, saliva, and tears become clogged. So again, you can read that for yourselves. That's the main thing. You don't need to know all of the individual ones. Just if you remember, if it's a duct, it'll get clogged. If it is an air passageway, it'll get blocked. Even sweat glands will produce more salty sweat. Because even in your intestines are producing more mucus, so because of that increased mucus, it can't absorb food as well. And there's lots of ductwork in our reproductive organs, so again, there can be some complications with reproduction due to cystic fibrosis. Potassium is the most abundant intracellular cation, so again, inside the cell. So again, it's important in maintaining proper fluid volume, impulse conduction, so this is your nerve signaling, as well as muscle contractions. Again, you have to have that concentration difference between sodium and potassium for all of that to occur. It's exchanged for hydrogen ions to help regulate pH. It's under the control of mineralocorticoids, mainly aldosterone, and that again, as you're retaining salt, you're losing potassium. And it's helping maintain that resting membrane potential in muscles and nerves. So we have hyperkalemia, so too much potassium. And we saw a little bit about this when we talked about the heart earlier on in the semester. The most common cause is related to the kidneys, either kidney failure or kidney disease. But there can be some other causes, Addison's disease, alcoholism, heavy drug use, anything that might damage the kidneys. Any of these things can cause hyperkalemia to occur. Bicarbonate is another important ion. Again, its main job is to help buffer at the acids of the hydrogen ions. And again, the kidneys are going to be the main regulators of these levels. So if there's not enough, you'll retain it. If there's too much, you will excrete it in your urine. Calcium is the most abundant ion in the body in general. That's not surprising. That's all of your bones. Again, big role in blood clotting. We saw this earlier. We saw the importance of it in the proper functioning of not just muscles. Like if you remember, it's the release of calcium that binds to troponin, which which pulls on tropomyosin, revealing the actin binding sites back in 201. It's also going to be important in neurotransmitter release. It's the influx of calcium into the synaptic end bulbs that actually causes the release of acetylcholine, as well as any other neurotransmitter. It's also important in that plateau in the heart. So again, very important ion. It's regulated by your parathyroid gland. The parathyroid gland causes osteoclasts to release calcium from the bone. And then calcitriol will help absorb calcium from your diet. Very low levels of calcium, as what you're looking at here, you can cause you can see it's a prolonged QT ECG period, so this part becomes longer. Some of the other issues are numbness, muscle spasms. That's not surprising, again, due to its role in muscle contractions. Seizures, confusion, again, cardiac arrest, again, its role in heart muscle contractions. Some of those causes, maybe low vitamin D levels, so again, you're not absorbing it from your diet. Simply malnutrition, you just don't have calcium to absorb. Maybe there's problems with absorption, so maybe you have things like cystic fibrosis or something else that may cause difficulty in absorbing it. You might not be producing enough parathyroid hormone, which again will help with the release and absorption of calcium, or simply problems with the kidneys. Hypercalcemia, again, is now too much calcium. So you can see here some of the symptoms. It can cause a strain on your kidneys because they have to work harder to filter it out. So there is, as with most everything, too much of a good thing. Too much calcium causes stomach upset, nausea, vomiting, and even constipation. Some of these are actually side effects of some calcium pills. So if you're ever, you or a loved one are taking calcium pills and then all of a sudden they're complaining about these, it might be the calcium pills. It might be taking too much. Excess calcium, oftentimes if you have too much calcium in your blood, it's because you're losing it from your bones. And that obviously is a real problem. You can lead to osteoporosis. It can also cause some muscle weakness, again, due to an imbalance in the concentration gradient. It can also interfere with the neurons in the brain. Again, anytime you do that, it can cause confusion, like muddied thinking, fatigue. So things that would cause hypercalcemia, overactive parathyroid glands, cancer, certain medications can do that, too many supplements, or simply dehydration. All right, so with that, we're going to move right into pH regulation. So how does your body handle pH? So remember this equation: carbon dioxide and water in the presence of carbonic anhydrase will form carbonic acid, which oh, that shifted on me, unfortunately. Oh, sorry, my arrows shifted. Should be arrows here, which will form bicarbonate and hydrogen ions. We saw this in the hemoglobin buffer system with carbon dioxide, the formation of hydrochloric acids. Lots of things use this equation because carbon dioxide reacts with water. Both of those things are very common in our bodies. Okay, so how do we, again, try to compensate our acids and bases? Well, there's a respiratory compensation and a renal compensation. Now, just think about this. Respiratory makes sense because, again, if it's carbon dioxide and water, well, the number one thing you're breathing out is carbon dioxide, right? And why we care is because if our blood becomes too acidic, it can cause I guess the proper term is a depression of the central nervous system, meaning it sort of decreases its activity quite a bit to the point of coma. That is really a decreased central nervous system function. And then alkalosis, or when the environment is too basic, or blood is too basic, I should say, it can cause the exact opposite. So instead of depressing the central nervous system, it is now highly excitable. So now you get convulsions, spasms, and that can also lead to death. Okay, so let's take a look at acidosis conditions first. So let's take, and there are two different types. You can either have respiratory acidosis or metabolic acidosis. And basically, the way that they are defined is pretty much by their cause, really. So let's just take a look at this. So respiratory acidosis is an increase in carbon dioxide and a decrease in pH. So again, as we have an increase in carbon dioxide, we'll form more of this carbonic acid, which means we will form more hydrogen ions. Well, the cause of this is hypoventilation, either due to emphysema, some pulmonary edema, airway obstruction, or simply even holding your breath, right? It causes a buildup of carbon dioxide, because again, you're not breathing it out. So again, we're causing more hydrogen ions to be produced, in which case, again, we have this acidic environment occurring. So because the problem is respiratory in nature, the only way the body is going to be able to compensate for that is with the kidneys, okay? So in this case, the kidneys are going to excrete more of the hydrogen ions, and it will try to reabsorb more of the bicarbonate. Okay, that's your body's way to compensate for that. Now, in the case of metabolic acidosis, and here it's defined as not due to an increase in carbon dioxide, but too little bicarbonate. And what's happening is usually there's a loss of the bicarbonate, either due to diarrhea, again, a renal dysfunction, or a very high level of ketosis. And again, if the problem is at the level of the kidneys, or your intestines, I guess, The only way to compensate for that is going to be via the respiratory system. So what you end up doing, you start hyperventilating, right? So as you hyperventilate, you're breathing out more and more carbon dioxide, which means you're pulling more of these hydrogen ions out of circulation to produce more carbon dioxide ions, right? So by doing that, you're decreasing the number of hydrogen ions, you're bringing your pH back into balance. Incidentally, like in respiratory acidosis, if someone says that they are going to simply hold their breath, you can tell them, go right ahead. Your body is very good at basically saying, look, you're holding your breath, you're building up your carbon dioxide levels, our hydrogen ion levels are increasing dangerously. We're getting into a respiratory acidosis situation. Frankly, like you start sending signals to the brain. We've all been there. We've all held our breaths. You get that kind of panicky feeling, like that real urge to take a breath. If you keep fighting that urge, eventually you will simply pass out. Basically, what happens, the brain just the sort of the conscious part of the brain shuts down, says, all right, medulla, all right, pons, you take over for our breathing for us. I don't know what we were thinking, holding our breath, but like clearly we need to like turn off and restart, because that was not a wise decision. All right, so then let's look at alkalosis. So that was acidosis, so when our pH is too low. Now what about our pH becoming too high? Again, we can have a respiratory reason or a metabolic reason. So in the respiratory alkalosis, the definition is a decreased carbon dioxide levels and increased pH, and this is usually due to hyperventilation. So when you like we were just mentioning just a moment ago, if I breathe out more, it will bring my pH higher. Now that is good if you're in an acidic sort of situation. It's less good if you're like hyperventilating. Like if you're just sitting there and you're freaking out and you're hyperventilating, you're also like now driving yourself to a respiratory alkalosis situation, which is bad. And frankly, at that point, your body will respond the same way, and you'll also pass out. Oftentimes people who are hyperventilating, they'll tell them to breathe into a paper bag, and they're breathing into and out of a paper bag so that every breath that they take has high levels of carbon dioxide, so this equation can go back toward the right and they can produce more hydrogen ions to prevent them from passing out. Basically, that's what you're trying to do. Okay, but in general hyperventilation situations, like if you have oxygen deficiency, like at high altitudes, basically your kidneys are going to compensate by decreasing the excretion of hydrogen ions, again retaining those, trying to drive the pH back down, and not reabsorbing as much bicarbonate. We do not need any more of that. We need more hydrogen ions to bring our pH back down. Now, in the case of metabolic alkalosis, in this case, it's an increased amount of bicarbonate, leading to an increased pH. A lot of times what causes that is a loss of stomach acid due to vomiting. Certain diuretics will also have that effect, and then as well as certain drugs. That should say respiratory is the compensation mechanism, not repertory, is hypoventilation. So basically your breathing will slow down. So again, by slowing down your breathing, you're going to build up more carbon dioxide. By building more carbon dioxide, you're eventually going to produce more hydrogen ions, which if you're in an alkalosis situation, it will bring it back down. Okay, so the moral of the story here is that if the cause is respiratory, the compensation is going to be renal. If it is a problem with either the kidneys or the digestive system, the compensation is going to be respiratory. Okay, that's all I have for this unit. If you have any questions, please let me know.